Thank you for having me, and good morning, everyone. So today I'm here to talk about the Eustachian tube dysfunction, which is one of the projects we started at Texas Children's Hospital. And we actually eventually supply most of our data to Acclarent too for their FDA approval. So this mainly just talk about our experience at Texas Children's Hospital. So is this a disclosure because I did supply my data to Acclarent, so now I am part of their consultant. So that is my disclosure with them. I also have research funding for a separate project with OtoNexus. So to talk about, when we come to talk about balloon dilation of the Eustachian tube, frequently we talk about, is it all encompassing for all Eustachian tube dysfunction, which is not. The balloon dilation for Eustachian tube is used only for obstructive Eustachian tube dysfunction and not for patchless Eustachian tube dysfunction. Patchless Eustachian tube dysfunction has its own separate pathology and management, which unfortunately I will not be covering here. I will briefly go over a little bit of it later part in the presentation. So in pediatric patient, what are some of the risk factors that it can cause kids to have obstructed Eustachian tube dysfunction? The most common issue we see is actually seasonal allergy, especially we're in Houston, fairly humid, always lots of pollen. So allergy is actually a very big component to a lot of kids that has Eustachian tube dysfunction. The other things to keep in mind are also kids with, adenoid hypertrophy, chronic sinus infection, reflux. But a good chunk of our patient also, due to us being quite a large tertiary referral center, we also have kids having craniofacial abnormality, including kids with cleft palate and other issues that can give them Eustachian tube dysfunction. Tumor is something that we do see it, but it's not as, I don't see it as often. And then in the kids, and then also you have to think about the kids with cystic fibrosis, the people with primary ciliary dyskinesia. So first thing is, how do anybody ever come up to the balloon, to come up with doing balloon Eustachian tube dilation? And so no one will come on flat to say this, but from talking to a lot of people, I think what happened is at some point, people start thinking, can we just dilate the Eustachian tube? Like really thinking more in the stretching sense to do the dilation, and rather than really understanding the pathology, but they somehow stumble upon success. But the more of a evidence came through around mid-2010, 2014, when Dennis Post and others started looking more into what change in the histology of the Eustachian tube after balloon dilation. So I always tell kids that these can only be done in adults. Somehow they got biopsy of the Eustachian tube mucosa before dilation and after dilation. So they actually got a pre-dilation, post-dilation, and at 6 weeks or greater follow-up. So what you can see is the number of the inflammatory cell has kind of, in the pre-dilation, you can see more of the inflammatory cell in the, let me see if I can get my laser pointer out, in the top layer. And you can see they get crushed immediately after dilation. And then 6 weeks follow up, basically the whole basal layer start regrowing a new layer, and all the tissue, the inflammatory cell number just drastically decrease. And the effect is actually long lasting, except if you don't have your allergy well controlled, this will return. So then there's also a research that went into looking in, if we talk about any other place in the nose, if we do turbinate reduction, will you have similar result? So it's the bottom picture here is all Eustachian tube dilation histology for the mucosa. As you can see, pre-dilation, immediately post-dilation and then the 6 weeks follow-up. In the top picture, what you're seeing here is actually the inferior turbinate dilation, which is very interesting. You're actually seeing exactly the same histology result of this drastic decrease for the inflammatory cell. And this is a little bit more important in a couple minutes when we start talking about the procedure part. So now, when we talk about eustachian tube dysfunction, a lot of time it's like, can we, quote unquote, diagnose them? Are there any tests that we can do to officially just say conclusively your child or an adult have eustachian tube dysfunction? So unfortunately, there's no standard test for diagnosis for eustachian tube dysfunction. And then it is the same when you looking at the American Academy's paper in 2019 from the clinical consensus statement. Again, this one is for adult only. So they're talking about balloon dilation for the eustachian tube for adult. If you really look, when we read into the paper, this is what most of us talk about as indication, the diagnosis to really talk about if they have obstructive eustachian tube dysfunction and if they are a candidate for getting balloon dilation of the eustachian tube. What they're talking about is you really talk as chronic otitis media with effusion for more than 3 months, or non-adherent atelectasis of the eardrum. Plus, you really need to diagnose them with a type B or type C tympanogram on the tympanogram, and also to see that they have eustachian tube pathology on endoscope. And again, this is all for adult. Or alternatively is if they have barrel challenge issues, so with scuba diving, and eustachian tube pathology on endoscopy. And this, for the one on the right, this is a part where you won't have necessarily the tympanogram finding. So this is all for adult. And initially the data was for a patient with 22 and over, then they drop it to 18 and over. And the December 2023 is when now FDA approval for only for the occurrent eustachian tube balloon for pediatric patient is now 8 to 17 years old. So this is the newer approval. I'm still facing issue with the insurance company from time to time because they're still using the 22 and over, the original FDA approval. But the newest one that came out in December is for 8 and over. So the current FDA criteria, if you want to consider doing balloon dilation or eustachian tube in kids, is for kids 8 and over. The recommendation is they fail at least one surgical intervention, meaning that at least try one set of ear tubes. You at least try to take out their adenoid. And this can be combined with ear tubes or not. It can be standalone. And physical exam is you should be seeing a middle ear effusion and possibly retracted eardrum. Again, with the audiogram, hearing loss is not absolutely necessary, but it is indicated it's more to look for a type B and type C tympanogram. But to tell the truth, some of the kids, I am seeing them depending on the time. I don't always see them when they have the type B tympanogram or type C. It's really depending on time, clinical presentation at the time I see them. Then lastly, the CT temporal bone, which was originally recommended, which is no longer a recommendation for doing a CT temporal bone now. It's because based on majority of the study that came out with a systemic review, there has been no carotid artery injury that recently with the current balloon. There has been in the past other balloon that cause carotid artery injury, and those are typically there are a size difference when it comes to that, and I'll show you guys the size. And all the other one that caused injury, I think was all from using a sinus balloon and not a specifically designed eustachian tube balloon. So, and then so when we work out for kids in my clinic to talk about potential for balloon dilation of the eustachian tube, history is the most important. It is selecting the right patient is the hardest part. when I first started looking into doing eustachian tube balloon dilation for kids in 2019, a lot of the patient that comes to mind is the one with, recurrent ear infection. But with time, they are still good candidate. But with time, is what I realized is the chronic otitis media with effusion patient are actually respond even better. So history taking is very important. When I first started, is I definitely look in all the kids' history. I take detailed notes on how many ear infection, how many sets of ear tubes, what kind of symptom are they experiencing that's really bothersome to them. And definitely getting an audiogram and tympanogram on the same visit. I make sure all the kids has allergy evaluation and treatment. So when I first started in 2019 to kind of make sure the allergy component is well controlled, I actually put all my patients on a 3-month Flonase treatment before I even consider dilation. Now I'm not as strict. I really, a lot of times I will just, get a detailed allergy review, and I still offer them to see an allergist if I feel like their allergy needs to be better managed before I do the eustachian tube dilation. One of the things I'm getting more aggressive on for kids is I actually do perform a nasal endoscopy on all the kids if I can. If they don't kick me too much, I will put in a nasal endoscope in the clinic. I do a 30 or 0 degree rigid, depending on what I have in clinic, to evaluate the eustachian tube lumen pathology. And this kind of go back to a little bit on patchless eustachian tube dysfunction. The patchless eustachian tube dysfunction and the one with obstructed eustachian tube dysfunction, their symptom overlap slightly. So on some of the kids, when it's not as clear what is a clear cause of their eustachian tube issue, I will put in a nasal endoscope. And I have been finding a lot more patients than expected that have patchless eustachian tube, which makes them not a candidate for balloon dilation of the eustachian tube. I used to get CT temporal bone to evaluate carotid artery, but we stopped that around 2021 when we realized there has been no evidence showing carotid artery injury if you use the procedure appropriately, if you do the technique appropriately. So for Acclarent, the reason my TCH we started to do it is because my partner and we like the safety feature that was offered by the ERA balloon. Again, there are Altera is another brand that is also a eustachian tube balloon. Just for consistency, when we first started in 2019, we just picked one and stayed with it. Part of it that what we like is the bulb tip at the tip of the balloon, which is a 2 millimeter bulb tip. It's because at 2 millimeter is bigger than estimated max diameter of the bony isthmus of the eustachian tube. So effectively, it pretty much prevents you from inserting the catheter into the bony part of the isthmus and causing a fracture if you're doing dilation. And this, to me, is a safety feature that I do like. I also do like that the balloon has a venting port, which can double as a suction port in a case where there's a little bit more drainage or bleeding during the procedure. It actually, so when you inflate the balloon, you're not putting pressure into the middle ear, thus decreasing potential trauma to the middle ear or the inner ear. So the length is standard for adult 6 millimeter diameter, 16 millimeter in the actual balloon, the part where it will achieve the maximal dilation diameter, but the whole balloon length is about 31 millimeter. So this is what will happen is when you inserting the balloon, the bulb tip will stop the balloon from entering into the, going past the isthmus of the bony eustachian tube. And once you dilate, again, the tip will keep everything in place without sliding. So what do I usually do is when I take it, and this procedure at least, actually, let me back up for a second. Let's go back to this picture. it's important to, why do we pick 8 years old as the age for dilation for kids? So initially, when I started at Texas Children, we actually picked 9 years old, and kind of going off with past evidence showing when does Eustachian tube start achieving better function. Typically, when we consider to doing tympanoplasty and any other ear procedure, we say 9, 10, 11 is when the Eustachian tube function starting to achieve more adult-like function. So at first at TCH, we did pick 9 years old as the starting point for balloon dilation. And later on, there is a paper recently from Utah, from Yu et al., which actually studied the Eustachian tube length in kids, and showing that 90% or more of the kids after 8 years old will achieve the same length of the Eustachian tube as an adult, which is estimated to be about 2 centimeters in total length. So for the cartilaginous portion. So that's why 8 years old end up being the point that is selected. So in kids, in adults, there has been talking about this procedure can be done in clinic, but in kids, due to discomfort, all the kids went to the operating room. So when we select the children that need to go to the operating room for the Eustachian tube dilation, we actually initially select all the kids that actually needs or we're considering getting ear tubes in, and they're the one we take. The first portion of our TCH original plan is all the kids are at most will get is a myringotomy without an ear tube if there's fluid present, or if there's no fluid, and we will just perform an examination under anesthesia of the ear, but without ear tubes. The reason we selected that approach, and we did discuss this with all the parents, is if we do put in the ear tube, we're not going to be able to tell if the Eustachian tube balloon dilation has worked or not. And the parent who decided not to still want an ear tube will actually get excluded in our original study. After the initial phase, and we currently are onto our more newer approach, where we take the kids to the operating room or confirm if there's presence or absence of the fluid. If fluid is present, we do put in acetopaparella ear tubes in the ear, mainly because paparella tubes will extrude generally about between 12 to 18 months. And we feel like that it gives kids enough symptom relief while still able to show us if the Eustachian tube balloon dilation worked or not. So then we follow by doing a nasal endoscopy and decongestion. We use this with a 0-degree scope and just afferent pledges. Then we out fracture the inferior turbinate, especially in the posterior end. And the reason for that is the inferior turbinate can cause issues with gaining access to the area of the Eustachian tube, especially in pediatric patients. We started out doing this, and I'll show a picture in a second, using a co-blader or microdebrider, but it actually still create a fairly bloody field and making the Eustachian tube dilation a little bit more complex. So now this went back to our earlier data on the histology change of the turbinate mucosal change even with balloon dilation. So at this point, TCH, we switch over doing a balloon dilation, inferior turbinate out fracture. So it create a fairly bloodless field and still achieve the same desired effect as the turbinate reduction or coblation. And at this point, we switch to 30 and 45-degree endoscope. I'll show you guys the difference in the views we get. We visualize the Eustachian tube lumen, then we perform the balloon dilation of the Eustachian tube. Hemostasis throughout the procedure can be achieved with afferent pledges, and then we'll repeat the procedure on the other side. So what I'm talking about is, this is what we typically look at in the kids, is this, here's a septum, here's a turbinate. This is before we start. And this is after we've placed the afferent pledges for decongestion. And this is after we're using the balloon for outfracturing of the inferior turbinate. So you can see clearly the view and the space will be getting after the outfracture of the turbinate. You might also notice the septum is actually now shifted over to the opposite side. So at the end of the procedure, we do keep in mind and we do kind of push the septum back more in the medial position in the end. So now, why is it important to use the endoscope? Because we have realized that you can visualize the eustachian tube lumen and the associated pathology much better if we can going from the 0 degree to 30 degree than to a 45-degree scope. Although 45-degree scope did take a little bit practice to get used to, but at this point, it is our standard practice to always use 45-degree scope to get a really important picture to help us visualize the eustachian tube lumen. So this is a more of an extreme case, as you can see. This is a 30-degree scope picture of the eustachian tube lumen. And this one, as you can see, the mucosal lining is severely edematous. What you can also see is there's mild adenoid hypertrophy, and this is after the child already had one adenoidectomy in the past. And especially in the anterior torus of the eustachian tube, you can see this lymphoid hypertrophic appearance. And this is a typical look that we are seeing in kids with chronic obstructive eustachian tube dysfunction picture. So let's say occasionally we do have child with very severely limited space in the nose, and we are really cannot get access to the eustachian tube lumen no matter what we do. And in this case, we have done before is you can use the endoscope in the nose, like in the side ipsilateral nose, that you want to do the eustachian tube dilation, but then you insert the eustachian tube balloon through the opposite nostril, and you can curve it into the eustachian tube if needed. Or in this picture, what happened is I have to use regular tonsil adenoid mouth gag and use a red rubber to mildly suspend the soft palate. And I insert the balloon through the mouth while the camera stays in the nose and gaining access into the eustachian tube. So so there are various ways to get the balloon into place if necessary. So now let's look at the video of one of the patients that we did a balloon dilation. This is with a 45-degree scope. So you'll feel like you're running into the septum constantly, and that is one of the things. There's mild bleeding from when we did a turbinate outfracturing. In this one, you can see we're using the catheter, the protective sheath to really identify the location of the eustachian tube. And here we're angling sort of in the superior to lateral position before we insert the balloon. And you can see the yellow catheter tip is at the outside of the eustachian tube lumen, and that indicate the full insertion of the eustachian tube balloon. And in here, you can see we gradually increase the pressure of the balloon. First, we increase it to 2 atmosphere pressure, and as long as the eustachian tube balloon is not slipping out of the eustachian tube lumen, then what we do is we'll increase it to 10 atmosphere eustachian tube pressure. Let me go to the next one. So this is actually the picture immediately post-dilation. As you can see, there shouldn't be any aggressive bleeding. There tend to be some mild mucosal irritation, but you can usually see clearly the post-dilation stretch of the eustachian tube lumen. In kids, we usually just do 90 seconds for 10 atmosphere pressure. We don't do the 2 minutes in comparison to adult, because there has been some studies showing that even at 60 seconds, you can achieve the same histology of the inflammatory cell crushing in pretty much any patient. And in kids, we tend to want to do it less to prevent the potential complication of temporary or permanent patchless eustachian tube issue. So in also at Texas Children, likely also combined with our Houston's aggressive allergy season, adenoid hypertrophy is a very common finding. So we have been more aggressively in evaluating and managing the adenoid hypertrophy. So usually we do it as one of our adjuvant procedure. So it can be primary versus secondary, or sometimes the most extreme case, I think I've done the adenoidectomy 3 to 4 times now, in a teenager with very severe allergy symptoms. So what we do is we will perform the traditional adenoidectomy with suction bovi. And this is done in kids, we usually ranging between 25 to 35 cautery setting, depending on preference. But what we also do, and this is in after discussion with Dr. Dennis Poe in Boston Children significantly, what he and a lot of other institutions would do is we'll actually drop the bovi setting to 10 and do gentle touches around the lateral edge of the anterior torus to kind of control the lymphoid hypertrophy around the eustachian tube. And that has not caused any children to have patchless eustachian tube dysfunction, but it definitely seemed to help controlling the amount of the eustachian tube function returning to normal. So most of the pretty much everyone would do it is to perform the adenoidectomy and the torus cauterization prior to the eustachian tube dilation, basically to help evaluating the eustachian tube lumen. But a small percentage of people will actually want to do the eustachian tube balloon dilation, then do the cautery around the anterior torus, because they want to see how much, they don't want to overdo the cauterization. Pretty much both way give you the same result, and there hasn't been a clear preference for one versus the other. Okay. All right, so let's go to the next one. So again, this picture is from Dennis Poe. The last picture was a Texas Children picture. So you can see it's fairly similar on how we're performing it. So what are the adjuvant procedure that you can perform to help with the symptom, including adenoid removal? Turbinate reduction, however you want to do it, coblation, submucosal reduction, or fracture. You can, in theory, combine it with sinus surgery, such as with the sinus balloonplasty or a maxillary antrostomy. Although in pediatric patients, we do not frequently combine it with sinus procedure. But the most important thing is medical management. You really do have to make sure their allergy is well controlled. So let's go back. So with the ear tube, earlier we talked about we will place ear tube when there's fluid. More recently, what we are doing is we'll actually also select on the type of fluid before deciding on ear tubes. If it's just a watery, small amount of serous effusion, we'll actually stay with a myringotomy and suctioning the fluid, and actually does not put in the tympanostomy tube. The one we do find that is really helpful to put in ear tube are the one with thick mucoid effusion. But again, we generally just only put in Pepperella ear tubes, because we do feel like these kids that's getting a balloon dilation does not need a long-term T2 placement. So there are some systemic review on eustachian tube dilation, and again, it's mainly adult. So what they have showed that is in the airborne gap, there has been showing in the kids with balloon dilation eustachian tube that actually have a statistically significant post-dilation reduction in airborne gap in comparison to kids that only get a ventilation tube or ear tubes. And also in the kids with balloon dilation of the eustachian tube, they actually does show that they have a statistically significant lower failure rate in comparison to the one that only getting the ventilation tube. So another study is, if you look at, these are purely pediatric patient now. In the pediatric patient, there actually are two studies. they actually both looking at kids with Eustachian tube dilation and versus ear tubes. So what they have found that is the kids with balloon Eustachian tube dilation has a longer failure-free probability compared to the one with ear tubes only. And these kids, they actually is painstakingly taken to control them in every aspect in terms of age, gender, I think even like race and past medical history. So these data are very significant in terms of showing that balloon dilation Eustachian tube actually does give you a better long-term outcome. So let's go to talk about at least a case, talk about what we usually do. So these are the type of children that I typically get referral from my partners. Will be like between, 8, 9, 10, 11, 12 years old, otherwise healthy child, but has multiple set of ear tubes, has already had tonsil adenoids removed. They have some mild seasonal allergy, and they're on Flonase and as needed for antihistamine. So typically when you see them, you see like right ear has a severe retracted eardrum. Left ear, you actually see a mucoid effusion and moderate turbinate hypertrophy. And the audiogram show that they hear okay in one ear with a type C timb, and then the other ear actually have a type B timb with some moderate hearing loss. We do have kids filling out the Eustachian tube dysfunction questionnaire, the ETDQ7 questionnaire, which give them a mean score of 3.1. So these are the Eustachian tube dysfunction questionnaire that's developed for adult. 7 question, a Likert scale 1 to 7. So on the mean score, usually when we divided them, if you score a score of 1.9 or higher, that means there is a symptom suggestion of Eustachian tube dysfunction. The reason we haven't discussed as much about ETDQ7 is because it is mainly for it is not meant for a diagnostic tool. It cannot diagnose someone with Eustachian tube dysfunction. Most of the time it's only used to track potential symptom relief. And it is only validated in adult only. It's not validated for pediatric patient. And that's why in TCH, we do obtain the ETDQ7 questionnaire, but we haven't found that it's as easy to track the data as in adult. So in this patient, he actually did end up getting a Eustachian tube dilation with he was our earlier patient, so he actually only got the myringotomy with drainage of the fluid with no ear tube placement. After about 2 months, his symptom actually did resolve completely with normalization of his eardrum to a type A, and with normalization of his hearing loss. And currently he's still in, he is only call us if he has issue, which he hasn't. So then this is another kid that got referred to us, but it's slightly older now and definitely has allergic rhinitis symptom. And they say they're just always stuffy. They always have to sniff and complain of the ear feeling full. And it does have recurrent middle ear effusion. When you look at the kid, you actually see a pretty severe retraction of the eardrum with middle ear effusion. And the nasal endoscopy, it actually looks pretty normal. So these are the kids you actually have to really be thoughtful on. And this is a reason we do nasal endoscopy in the office. This is because that this kid actually likely has a patulous Eustachian tube, but is masking a little bit as a obstructive Eustachian tube dysfunction because it does have fluid in the middle ear. So it is basically these type of symptom with a chronic, when they are so severely allergic, they're constantly sniffling. And when they sniff, they actually create a pretty strong negative pressure into the middle ear by slamming down in the Eustachian tube lumen from the torus. They're basically kind of closing in on itself every time you sniff. And with time, the mucosal layer over in the Eustachian tube in the beginning actually kind of gets what we call burned out. They actually become atrophy. So the eustachian tube become bigger and bigger. So the kids, every time they sniff in, they create more and more negative pressure. So eventually they will really start causing severe retraction to the point of causing cholesteatoma. But they can still get middle ear effusion again from the negative pressure. So they can actually go both hand in hand. And these are the type of patient that does not, the eustachian tube dilation will not help them. They really do just need the traditional tympanoplasty with a strong cartilage graft. So what is the most common complication is nosebleed. And usually it's simultaneously resolved. And these are the one that's being reported in the past systemic study, and it is consistent with what we're seeing at Texas Children's Hospital. It is a nosebleed. The second most common complication and is a hemotympanum or oral fullness, mostly likely related to the mild mucosal stretch injury from the dilation, but it typically self-resolve within 4 to 6 weeks. And there has been no report of the carotid artery injury or permanent patulous eustachian tube dysfunction. In TCH, we do have kids that have temporary patulous eustachian tube dysfunction that resolve usually within 4 to 6 weeks. We have 2 of those patients over time. So finally, with the coding, the newest coding for balloon dilation of eustachian tube for unilateral is 69705. For bilateral is 69706. So the rigid nasal endoscopy code is already embedded in this code, so you do not code a separate nasal endoscopy. You can code for any type of turbinate reduction procedure if you do combine them with them. And we do always we do always code for laryngotomy or with or without tube if necessary. So for our kids, we actually strictly say no nose blowing for 1 week. We really don't want you to blow anything into your middle ear at this point. And we actually do a modified Valsalva procedure starting at 1 week for the next 4 weeks. What it meant is we ask the kid to take a small breath, pinch their nose, close their mouth, and swallow against all the closing nose and mouth. And we ask them to do that 4 to 6 times a day. This is a little bit more gentle than the regular Valsalva, which not all of the kids is able to perform, but modified Valsalva, they seem to be doing well. And they have to continue their medical management as indicated, because I do have one child who received amazing result from balloon dilation of eustachian tube dilation. He's about 13, and because he feels so good, he stopped his allergy treatment. A year later, his issue returned. So we have to re-dilate him. And this time I really strongly against him from ever coming off allergy treatment, at least for a while. So the factor that seem to determine long-term success, again, allergy management, medical management is really important. And we do find that adenoidectomy seem to be a driving factor, as is a frequent adjuvant procedure performed together. And I do like to thank my team, Dr. Paul, Dr. Mukherjee, second from the right, Dr. Martin. We are kind of like the 4 people that have been talking a lot on eustachian tube dilation, and I turn to them for a lot of my questions frequently. So thank you, everyone.